Welcome everyone to my 9-month progress report, and I would like to present you some of the research work that I have been doing since September in the clinicopathological evaluation of cutaneous lupus. My name is Laura Bokor. I'm a medical doctor and a full-time PhD student at the Department of Dermatology at Semmelweis University, and my supervisors are Bernadett Hidvégi and András Bánvölgyi. My vision is to improve the quality of life of patients suffering from cutaneous lupus, and in order to achieve this, my mission is to find more efficient therapeutic options for this disease. Currently, I have 2 ongoing projects, both in the topic of cutaneous lupus, but I am using different methodologies. My first topic is the investigation of the efficacy and safety of novel therapeutical options in cutaneous lupus, and I am doing a systematic review and a meta-analysis. So first, I would like to share a few pieces of information on this disease. Cutaneous lupus is an autoimmune skin disease. There are more than 300,000 new patients every year worldwide who suffer from inflamed, scaling, or scarring lesions, or they might have scarring alopecia. Due to these symptoms, they have a substantial decrease in their quality of life. The gold standard therapies for cutaneous lupus are either topical or systemic glucocorticoids and antimalarials. But unfortunately, as you might already know, glucocorticoids might have serious side effects, and the response rate to antimalarials is unfortunately approximately 50%. Recently, novel therapies have emerged, for example, biologics, like a very promising one, anifrolumab, or small molecules like JAK inhibitors, but there's only limited evidence available on their efficacy and safety in cutaneous lupus. So therefore, our aim is to find the most effective and safest novel therapy in this disease. Our clinical question is quite similar to our aim: what is the safest and most effective novel treatment in cutaneous lupus? To answer this, we are using the PICO framework, where our population is patients with cutaneous lupus, and we compare biologics and small molecules to placebo or no comparator at all, and our outcomes are efficacy and adverse events. We measure efficacy with the CLASI score, which is a specific score that measures the activity of cutaneous lupus from a scale from 0 to 70, and the number 50 means that the number of patients who have reached at least a 50% reduction in their CLASI activity score after treatment. Our hypothesis is that anifrolumab is the most effective and safest novel therapy in cutaneous lupus. We conducted our systematic search in the end of November, and here's the flowchart of my selection. I started with over 80,000 articles, and I ended up with 58 full texts. So I would like to introduce you to the structure of my meta-analysis, since there's 2 parts of it. There's a network meta-analysis of the randomized control studies and the standard meta-analysis of the observational studies. And we investigate the outcomes of a number of patients who have reached this CLASI 50 score after treatment, the odds ratio of any adverse events, and the odds ratio of serious adverse events in both parts. Here you can see my network meta-analysis plots with the direct comparisons between these novel therapies and placebo in terms of efficacy and safety. So I would like to present you my results regarding the number of patients who have reached at least a 50% reduction in their CLASI activity score after treatment. On the left-hand side, you can see my net forest plot, in which all novel therapies in cutaneous lupus are compared to placebo, and you can observe a clear ranking between them. And according to our results, deucravacitinib came out as the most effective therapy of all, since more than 8 times as many patients have reached at least a 50% reduction in their disease activity when receiving deucravacitinib compared to those who received a placebo. On the right-hand side, you can see my p-score plot, which shows how confident we are in our ranking. And down below, in my league table, I would like to highlight some of the indirect comparisons that we have made during our analysis. In this league table, on the upper right-hand side, you can see the few direct comparisons we have, and on the lower left-hand side, you can see the indirect comparisons. According to our results, deucravacitinib and litifilimab was significantly more effective than baricitinib and ustekinumab, and anifrolumab was significantly more effective than ustekinumab when treating cutaneous lupus. Here's the safety profile of these novel therapies. Again, all therapies are compared to placebo, and we can observe no significant difference between these novel therapies and placebo in terms of the odds ratio of any adverse events. And moreover, there were also no differences and no significant difference among these novel treatments with the indirect comparisons, so we can conclude that these are safe therapies. And here are the serious adverse events, where in the net-first plot, you can see that there were no significant difference between these therapies compared to placebo in the odds ratio of serious adverse events, except for baricitinib. I would like to highlight some of the strengths and limitations of my study. My study is a comprehensive meta-analysis of these novel treatments in cutaneous lupus, and we have a network meta-analysis part, and also we work with high patient numbers. But our limitations include that there's a high heterogeneity in the CLASI outcome, and we have only a few direct comparisons. In conclusion, deucravacitinib is the most effective and well-tolerated novel therapy in cutaneous lupus, and this study could help to choose the most effective and safest novel therapy for clinicians, helps clinicians to choose the safest novel therapy in cutaneous lupus. But more randomized controlled trials are needed for each therapy, and we need the unified efficacy measures in cutaneous lupus. This is the progress of my first project. I'm currently writing my manuscript. And jumping to my second topic, which is the epidemiological evaluation of patients with cutaneous lupus, and this is a retrospective cohort study. So the incidence of cutaneous lupus is around 4 over 100,000. However, there's still few available data on the epidemiology of the different subgroups of cutaneous lupus, so there are several open questions about the difference in gender distribution in the subgroups, the prevalence of autoimmune or malignant comorbidities, prevalence of systematization, or the epidemiology of the rare subtypes. Unfortunately, there's only one previous register available, which was published in 2013, and it collected data from 4 years, and it contained the data of a bit over 1,000 patients. So our aim is to collect data from the last 10 years at the Department of Dermatology at Semmelweis University, which is one of the biggest centers for autoimmune skin diseases in Hungary. And we aim to analyze the prevalence of these rare subtypes, the male-female ratio, the prevalence of comorbidities, smoking, systematization, or for example, the first, second, or third-line treatment options in Hungary. So all in all, our aim is to provide an up-to-date epidemiological data on cutaneous lupus. In summary, these are my 2 ongoing projects. The first one focuses on the therapy of cutaneous lupus, and the second one on the epidemiology of the disease. And I would like to thank you for your attention with the words of Banksy, which motivates me all the time. If you get tired, learn to rest and not to quit. Thank you.
Thank you for your nice presentation. I would ask regarding to your first project, as I understand well, the patients who treated with baricitinib have significantly more side effects compared to placebo, and what were they?
Yes, so they had significantly more side effects, and they were mostly infectious diseases, especially herpes and upper gastrointestinal tract infections as well, and other different kinds of urinary tract infection diseases. These were more significant in that group compared to placebo.
Thank you.
I have a question regarding your hypothesis. Why did you choose anifrolumab as the most effective and safest, but your results did not suggest that, actually?
Yes, we've chosen anifrolumab because of the mechanism of action of the disease, since it blocks the type 1 interferon receptor, and the type 1 interferon route is the main pathological way in cutaneous lupus. So that was our hypothesis, that since it targets the main pathological way, it might be the most effective, but it turned out that it's not unfortunate. Not unfortunately, but it's not, yeah.
And based on your experience, when do these patients actually seek the medical help? Because based on the pictures you showed, like they have an obvious lesion in their skin. But when do they actually seek the medical help? In early stage or in an already advanced stage?
So usually there are two types of patients with cutaneous lupus. The first one who already has systemic lupus, so they're under observation by their nephrologist or internal medicine doctor. And when they have a skin condition, they immediately refer them to dermatologists. So they are the ones who get early treatment. And the second one, usually they go to the doctor like in a short period of time, since the symptoms are quite disturbing. But the problem is that they usually have the diagnosis in like 4 or 6 months, since sometimes it's not very typical or difficult to diagnose, and it takes time to get them to a center.
Yeah, all right, thank you.
Yes, and hello. Thank you very much for your presentation. Please, can you clarify? Maybe I just missed it from the presentation. So your first project and the figure when you showed the effectiveness on the drugs, different ones, it was the odds ratios, right? Can I ask about the timing, because odds are dependent on the time in most of the cases. So the prescription of different drugs were similar in the period of
So you
treatment?
mean the period of the trials?
Yeah,
Yes.
the drug prescription.
Yes, it's a very good question. We had a problem with that, since they had different trial periods, usually from 12 weeks up to 52 weeks. So it was a high heterogeneity in that, but as we read, they all optimized these trial dates based on the drug itself, so how it needs to have an effect, and for the adverse events to, so we can see the adverse events. So there's a problem, but eventually with the statisticians and my supervisor, we decided that we won't include it in the analysis, or we could not do a subgroup analysis based on that. So.
I see. Thank you very much.
So the type 1 interferon pathway is an important, has an important role in the pathogenesis of this disease. So what can you tell us about the type 1 interferon receptor antagonists?
So we only have anifrolumab. That is the only one that we currently have. In these trials, so I didn't mention it in my presentation, but anifrolumab was also significantly more effective than placebo. However, not as effective as the deucravacitinib, which is a TYK2 inhibitor. They don't know why. There have been several articles published because many of them hypothesized that this would be the most effective drug. The safety profile is very good of these treatments, quite low infection rate. There's no like thromboembolism problem like they have with the JAK inhibitors. So it's a very promising drug, but it seems that for the cutaneous part, not this type of drug is the most effective. Yeah.
Okay, so in your study there is a cutaneous lupus erythematous, and so there is a classification. There are several classifications, but maybe the most accepted is a Gilliam classification, so there's specific, non-specific. In your study, did you find any difference between the efficacy in the different cutaneous symptoms, discoid or subacute cutaneous, etc.?
Yes, we would really love to see these differences, since, for example, discoid lupus is way more difficult to treat. But unfortunately, many of these trials were conducted on patients with systemic lupus, and they mostly focused on the systemic part of the disease, and only a few of them even mentioned the cutaneous domain, and they did not publish whether which types were in that cutaneous part, but it would have been very nice, yes.
I see, thank you.